Well, welcome back, everybody, and thanks for coming back. There's always that anxious moment, you know, the room's going to be empty, but thank you very much. Can I just politely remind you, if you could please complete the surveys for the trials that you're involved in, we'd be really grateful for that feedback. There is an attendance thing going around, so we know who's here, so we can say to, you know, as I said this morning, demonstrate tangibly to HGA the excellent level of engagement we've had for this meeting. And not to forget the all-important quiz for valuable prizes, which will be awarded at the end of the day. So the next session, we're going to move from BASIL-2 to BASIL-3. BASIL-3 isn't quite the problem child that BASIL-2 is, but you will see from the data we show that we're not really recruiting at the rate we would like to. And so we'd like to spend a while just, you know, taking stock of where we are with that trial, and again, getting your feedback and interaction on that would be really helpful. So without further ado, I'm going to hand back to Lewis Meecham, Research Fellow, and he's going to talk to you about why we need the trial.
Good afternoon. I hope you don't fall asleep after lunch, but I'll try not to be too boring. So, as Prof has already alluded to, BASIL-3 should be an easier trial to recruit to because you're not choosing between a bypass or a surgery arm and an endovascular arm. These are all endovascular interventions and therefore reasonably easy to consent patients to enter, and yet we're still finding that we're having problems entering people into the trial. One of the statements that is regularly fired at us as the trial team is that there are already a lot of randomized controlled trials with drug-eluting technology, and that they know that it's better than plain balloon angioplasty, so why are we doing a new trial? And so my job in the next 5 minutes is to try and give you an understanding of the literature that's out there already and why BASIL-3 would be different. So I think the slide is quite big and complicated, but what the message I'm trying to convey is there are lots of industry-sponsored trials. They have tried very hard to prove that drug-coated balloons are better than plain balloon angioplasty. And they've entered quite a lot of patients. And to be fair, they have proven that radiological outcomes are probably better within the first 12 months for drug-coated balloons. They've got better freedom from target lesion revascularization, better binary restenosis. However, none of them have proved that there's any difference in the clinical outcomes past 12 months. And that's to do with walking distance mainly and amputation rates. Now, most of the patients in these trials were claudicants, more than 90% in the majority of trials. So there's very few critical limb ischemia patients. And even those that have critical limb ischemia have Rutherford force or rest pain. So it's not really applicable to our critical limb ischemia patients. And we don't have any evidence to say that they're actually better on a clinical effectiveness side. Drug-eluting stents, there's less trials comparing stents versus just plain balloons, which I would argue is still the standard of practice in the UK. The Silver PTX study was a reasonably large study, but again, 90% claudicants and 0% versus 0% amputation, which is what you'd expect in claudicants, but actually didn't really show much improvement in walking distance, sustained walking distance or ABPI at 12 months. But the primary patency, or primary assisted patency, was 83.1% versus 32%. So there would be some suggestion that the radiological or the anatomical markers are much better for these technologies. There are many other trials comparing drug-eluting stents with stents, but I'm not going to go into them because I would assume that most people here don't primarily stent people's SFAs, but use it as a bailout option. So in summary, almost all of the trials for these technologies are industry sponsored and therefore biased from the point of view of showing good results. Nearly exclusively in claudicants. If you do have CLIs, mainly rest pain. They're very highly selected patients in centres that do a lot of angioplasty with short lesions that are favourable for outcomes in patients with endovascular technologies. And most of the endpoints are anatomical. These are non-inferiority analyses as well. So they're designed to prove that they're not worse than the technology that we have, not better. And so there's no real evidence at the moment that they are better in the real world. And that's what we're trying to prove with BASIL-3. So NICE in 2012-2017 reviewed the topic, and they at that time had decided not to endorse drug-eluting technology, and we're waiting the results of BASIL-3. And some of you may know of the new document that's come out for consultation, but drug-eluting technologies in that document is for intermittent claudication only. Matt alluded to the Cochrane review earlier on, which essentially said that the radiological outcomes were better for drug-eluting technology within 12 months. However, this did not correlate with clinical benefit. And some of the systematic reviews that have been performed at the same time all conclude the same thing, essentially, that it's promising, the new technology might be beneficial, however, we need more trials. So what are we doing? We're doing a trial. And then the other thing that is said to us very often is that people's use of endovascular technologies increase. They're far better at the techniques, and the technologies are better, therefore the outcomes are obviously better. Everyone always says that to us. So we went back and looked at the contemporary series in heft that had femoral popliteal plain balloon angioplasty with or without bailout metal stenting, bare metal stenting between 2009 and 2013. And what we found was that technical success rate was non-statistically better at 89% versus 83%. So we were better at doing the technologies. More patients were successfully treated at the end of their angioplasty. But what we found in amputation-free survival was that those benefits weren't sustained, weren't translated into clinical benefit over the long term. And if we was to zoom in the first 30 days of that graph, you'd see that the contemporary series line is probably better than the BASIL line. So in the short term, we're getting more people through procedures with better outcomes, but that doesn't translate into the long-term benefit. Now, I accept that this is a contemporary series versus randomized cohort, and that there might be some Hail Mary angioplasties in there. But the 30-day outcomes would suggest that they are probably less of an effect, and this is just that people with critical limb ischemia are doing worse now than they did 10 years ago. So our advances in technology have not translated into advances in patient outcomes. So we need more information as to why. The last thing I want to talk to you about is my personal bias before we started the trial was that the patients in BASIL-3 would experience less clinical events than BASIL-2. People with infrapopliteal disease would have done obviously worse in my mind. The amputation-free survival graph for BASIL-3 at 1 year and BASIL-2 at 1 year is exactly the same. 74% in BASIL-2 amputation-free survival at 1 year, 72% in BASIL-3, which is striking. I honestly can't explain it. And maybe it would explain that actually a lot of the problems these patients are getting are not procedure related. So I would encourage everyone to put patients into BASIL-3 that are having SFA or popliteal endovascular treatment, because we still don't know if drug-eluting technology confers a clinical benefit for these people.